Okay, so welcome to Swoding Institute's Shortly on Demand. This is webinar 26 and it's entitled So You've Made It Worse. So starting off a good foot, basically. But first, let's have a look at the quiz. So what we have is photographs of the mouth. On the upper left one, this is all part of a cranial nerve exam. The patient has been asked to poke out their tongue, and what you can see is it's deviating to the left. Not only that, but on the left side, you can see the tongue is actually atrophied, while on the right side, it's nice and fully formed. But it's a nice dividing line right down it. So the question is, what's causing this? The other photograph is of the uvula during the phonation tests, say R. And on the picture on the left of the screen is a normal rate, and you can see that the uvula stays pretty much in the center. The arches of the soft palate both go up about equally. While on the other side, under my head, so if I can get out of the way a bit, you can see that the uvula is deviating over to the right side, and the left arch isn't elevating anything near as much as the right. So what's going on here? And answers as usual at the end. So, as I say, what we're talking about today is you've treated the neck in this case and you've made it worse. And worse in this case means you've given the patient a couple of symptoms they never had before, either dizziness or headache or a combination of both. And obviously the dizziness is the one you're going to be mostly concerned about. And of course, the first thing you think about is vertebral basilar ischemia. Fair enough. You're right to be concerned, but mostly this is going to end up as a fairly benign condition, and it's usually due to a proprioceptive screw-up. Basically, the patient's been fumbling along with neck pain, movement dysfunctions in the neck, and the cervical input into your balance system is massive. So basically, and it's also very plastic and adaptive. So it gets used to it and it functions with it being dysfunctional. Then you come along and you make a change to it. Mobilization, manipulation, doesn't really matter. But you make a change to it and it's a sudden change. And now it has to readapt again. And this it can't do, not that quickly oftentimes. So the result is a conflict in the system. It's getting abnormal, well, it's now normal, but the system is abnormal signals from the neck. And so you end up with dizziness. So mostly this is going to be benign by a very long distance. So panicking here isn't the best idea either for you or the patient. So before we get too carried away and send it off to the emergency room immediately, there's a couple of questions we can ask, and we can try to make a determination of how serious this is and where should we send it if we're going to send it anywhere, either back to the physician, to the emergency room, or can we keep on with it? But you do not touch the neck. There's no movement tests done in the neck, because if you have damaged the artery, the worst thing you can do is release an embolus. And this is one of the big things that's found with manipulation. It's not the preceding manipulation that causes the problem. It may cause the symptoms and it may damage the artery, but the real problem begins when they release an embolus. So, and then how bad this problem becomes depends on how big the embolus and which artery it blocks. So let's not take risks with this. We won't move the neck. We'll play it as if you have damaged your artery and we're looking for a reason to send it to either back to the doctor or to the emergency room to be sure. But even if you want to send it back to the physician, there's one or two things you can tell them. And also, if it goes to the emergency room, there's some things that you can find out that might be useful to them as well. So let's not panic and rush to do it. So let's have a look at bit of a diagram. So how can we get information from them? Well, what we're looking at here is a new symptom, all right? The patient came in, there was no reason to suspect they had a vertebral artery problem. They had no headache, no dizziness, certainly not a combination of the two. It may or may not have been trauma, but you decided that there really wasn't any contraindication to you testing an occlusive test such as declines. And you carry out the decline test and everything's fine. Now, Vertebropathic ischemia, an injury, is considered an unavoidable risk with spinal manipulation. I think it can be avoided to some extent. The risk can be reduced, but if we go with what's normally said about this is as an unavoidable risk, what we want to do is not damage it again. Now, the reason why this may be an issue is an asymmetry in the sizes of the arteries. So it's generally the right artery can be much smaller than the left. And if it's less than 1 millimeter in diameter, then it's pointless. There's no use to it. The normal diameter of the vertebral artery is about 4 millimeters, about 1/4 inch. But if it's less than 1 millimeter, it may as well be absent. It can be absent. We can have unilateral absence. We can also have bilateral absence, but it can be absent. And also you can have a condition called atresia, where the artery, instead of injecting into the basilar, terminates at the posterior inferior cerebellar. Now, if you damage the normal artery, what you're left with is the abnormal artery, which may not be sufficient to deal with the problem. So if we block the atretic artery, if we block the good artery and the other side is an atretic artery, we have no hindbrain brain blood going into the basilar artery. So now you're entirely dependent on what's coming through the circle of Willis from the anterior circulation, the carotids. So that ain't necessarily a good thing. Similarly, if the right is absent and you damage the left, or the right is hypoplastic and you damage the left, you're reducing the flow through the basilar to a trickle, if any. So these are some of the reasons why this may get damaged. There's also structural anomalies that can occur there as well. But it can get damaged from your manipulation. So they're dizzy. The first thing to find out is what sort of dizziness are we talking about? Now, if this is vertigo, then it's either going to be peripheral or it's going to be central. Now, it's really difficult to see how you can produce peripheral vertigo with a spinal manipulation, unless you consider blocking the auditory artery, causing a peripheral neuropathy, basically. But let's not do that because it's still caused by a vascular problem. So if you're finding this is a peripheral problem, this is severe, short duration, non-persistent, no neurological symptoms at all, then fine, we can fire it off to the MD. If on the other hand this is central, then there's a cause for it. And you basically, unless you slam their head on the floor, this isn't a brain injury, so it could be neurovascular. So if you're finding evidence of central vertigo, that is now, it's mild, persistent, alternating in direction and so on, don't do any movement tests, fire it straight off to the emergency room. And you can see this in this direction going up here. Okay. If on the other hand, this is type 2 dizziness, pre-syncope dizziness, this is less easy to classify as far as the etiology is concerned. So if this is pre-syncope, then you got one of two questions. Is it improving or isn't it improving? Now, if it's not improving, then the chance of this become a central problem has just gone up a lot. These things should be getting better inside 15 minutes or so. Now, if it's not getting better, at least it should go back to the MD. Now, if they're dizzy when you're seeing them, a cranial nerve exam is going to be useful. And if they've got a positive cranial nerve exam, I would send it to the ER. But assuming there isn't a positive cranial nerve exam, it should go to the MD. If you're not sure, send it to the ER. Now, if it is improving, and it's significant improvement, I mean, they're quite clear that it is a lot better today than it was yesterday, then it's probably peripheral. And there's a couple of things you can do. Again, make sure there are no neurological signs with a cranial nerve exam. And then you can try and do some non-specific grade 3 modes. So large amplitude modes, not pushing the barrier, but just large amplitude movements to input proprioception. Now, if this is a proprioceptive screw up, then it should improve the dizziness. If so, that's basically what it is. You can just sit and wait for this to get better. If it doesn't improve it, again, get it back to the MD. Now, on this side of the equation here, it's all the same thing. So they've got dizziness. We could have done this. We could have gone another route. Instead of looking at what type of vertigo or what type of dizziness dealing with, we could have asked them, is the dizziness continuous or discontinuous? Now, if it's continuous, don't do any movement tests, but you can certainly do a neurological exam. If it's discontinuous, or if it is continuous, get it out anyway, but do a neurological exam to give a bit more information. If this is on and off, there's the cranial nerve tests are positive, or you have hard neurological symptoms or visual disturbances, don't do any movement tests. Again, get this straight off to the emergency room. So you can go in either one of these two directions. My preference personally would be to be looking at what type of dizziness I'm dealing with and go in that route. But you should end up doing both anyway. Both of those questions are pertinent to what you're looking for. So even with dizziness, there's no need to panic. Now, if the first thing you do when they come in is a cranial nerve exam, which isn't the worst thing in the world to do, if they have dizziness and they don't have positive cranial nerve tests, then you should be much more comfortable about it not being caused by neurovascular problems. If, on the other hand, it's discontinuous, then you really don't want to be trying to make them dizzy because you have no idea what's going on here. So, but a cranial nerve exam is good because if you do pick up positive signs, that's your reason to shoot them out the door. And if you're finding hard central signs, it goes to the emergency room, not to the MD. Okay, the other symptom you're going to be concerned about, obviously, is headache. And our new symptom now is headache. So if this is a non-spondylogenic headache, that is, it's not localized to the back of the head, it's coming over the top, it may be off to one side, it may be isolated, it's not sharp and well defined, it's deep and dull and diffuse. Particularly if the patient has any cognitive issues, they're having trouble concentrating and so on, you may be looking at something like concussion, or this could be an intracranial bleed, but the chance of you causing an intracranial bleed is not very high. Chance of you causing concussion unless you smash your head on the floor is not very high. But given it's non-spondylogenic, you don't really know what it is. So you're better off being very cautious with this. Do a cranial nerve exam, regardless of the result of that. Don't do any movement tests, send it to the emergency room and give them the result of your cranial nerve exam. If the headache is spondylogenic, then it's probably coming from the neck. Now, if there's no dizziness associated with this, it's not likely to be VVI. So we can now look at doing non-specific grade 3 MOBs the way we did before. So if this doesn't improve, you get it back to the doctor. If it improves, it's probably spondylogenic, and you just carry on with the treatments. If this is a combination of dizziness and headache, then we've got that situation we had all the way through these discussions on a neurovascular problem. That is, these two symptoms together are not good. So you have to go through the association, dissociating, coupling, decoupling questions, do a cranial nerve exam, and try and figure out whether or not you're okay to move the neck. So if these two are combined this way, you're probably better off just firing it straight out to the emergency room. Don't do any movement tests. Certainly do a cranial nerve exam for information to the doctor, but then get it to the emergency room. So this is how I would go about trying to sort out whether or not I can carry on with this patient or I need to refer it. The problem with referring this out when you don't need to is you're going to scare the hell out of the patient, and you're going to make the physician wonder about whether or not you're competent. So it's not that you want to hang on to these people if you've got any doubt about it at all, but make sure when you send it out, you're fairly confident that you're right to do this. Similarly, if you're going to keep them, don't charge in them too fast. You're going to wait and see what happens, all right? Rather than do another manipulation. Just wait it out and see what happens. And I would be, what you're looking for is, if this is appropriate separate screw up, is for the dizziness and or headache and the neck pain to improve at the same time. And then you can be reasonably comfortable over a couple of visits that you don't have to worry about this patient. The last slide, for our purposes here is simply all of this in one go. And this is what it looks like. This is the whole thing. And I'll just leave it up there for a minute and you can look it over. But as I say, don't panic about this. But if you really believe that you've done some neurovascular damage, it's not good enough to say go to the emergency room. You probably need to phone for an ambulance and get them taken there. And don't manipulate them again when they come in the next visit. Make sure they're actually improving, and then be really careful about where you're going with this. I think it's worth remembering, though, that this can occur, VB injuries can occur with exercises, and there's no reason why not to think about mobilization of doing this, but certainly exercises can cause this as well as manipulation. There's been a couple of cases where this has happened. It's not always old people neither. So your manipulation may do some damage, it may not. And the title of this is So You Made It Worse. The question is, did you just make it worse temporarily on its way to getting better? So don't panic the patient. Send it to the emergency room if you have to, calmly and carefully, with as much information as you can give to the physician who's going to be seeing it. And if you don't think to go to the emergency room, it goes to the MD. And it's their patient as well, after all. So be courteous, if nothing else. Okay, so I hope that worked for you. I'm going to give you the answers to the quiz now. And the tongue sticking out. This is a hypoglossal palsy on the left. The tongue, when it comes out, protrudes out as if you imagine it being pushed out by a couple of pistons. Let me see if I can get me back on here. If you imagine the tongue being pushed out by a couple of pistons here. So they're pushing that way. And in this case, the right piston, actually their right piston, the right piston, I was right. The right piston is pushing harder than the left. So it swivels the tongue to the weak side. And of course, the atrophy is also a giveaway there. With the uvula, the situation's reversed. On the photograph, where it says deviated, this is pulled to the strong side. So in this case, it's being pulled to the right by the strong uvulary muscles over that side it's pulling. But the arch on the left, which is the side of the palsy, is a vagal nerve problem, is failing to raise as much as the other. So this is showing you that you have a vagal nerve palsy. And this is all part of the cranial nerve exam. So I hope all of that was helpful to you. I'll talk to you next time we do this. This photograph is about a quarter of a mile from where I live. We've seen that before. If you look at the tree up on the right-hand side there, left-hand side of the screen, then, sorry, yeah, this is flipped me, I'm sorry. So on that side of the screen, that high tree there, we've seen that one before on one of the previous webinars, but I was at the other end of the lane looking over the lake and towards the mountain. So this is looking the other way up to the mountains behind the house. So I'll hope you enjoyed this, and I will see you next week. Bye-bye.